Now call Encik Azmar in analysis to present this episode. Yes, sir.
Okey, Assalamualaikum warahmatullahi wabarakatuh. Terima kasih Cikgu Sri Majlis. Yang saya hormati pada hari yang datang untuk CME pagi ni. Saya minta maaf sebab lambat sikit. Saya tak pernah drive kat sini sebenarnya pagi. Saya selalu pergi kerja yang kaki. Sebab saya baru pindah sini kan. So saya tak jangka trafik dia macam ni. Okey, tak apa. Saya akan try habiskan sebelum pukul 9. Sebab saya tahu semua orang ada something else to do lah. Okay, saya akan cakap pasal stroke rehabilitation, specifically how the speech therapist can help the adult cases. Okay, move. Slide anyone? Okay, dah boleh. Alright, so this is my content of presentation. Saya akan cakap pasal the overview of the stroke rehabilitation. What are the different types of communication disorders after stroke? What are the treatment of communication disorders? And also I'm going to talk about swallowing problems and also a little bit of assessment and the treatment recommendation for swallowing problems. Okay, so this is a case of Lorraine. Okay, after her 60th birthday, she had a stroke and she had a coma for weeks, and her husband was told that she might never walk, talk, and understand anyone again. The grandmother of 8 defied expectancy by waking from the coma, but lost mobility in her right side and is unable to speak. This is quite common condition for any stroke patients. Many of the stroke patients, after they will recover from their medical condition, they have some issues, and especially communications and also physical problems. Okay, so basically what is a stroke rehabilitation? Okay, so I think many of us, I think perhaps working with the stroke patients, the goal for the stroke rehabilitation is for us to help the patient to regain independence and improve quality of life. That is the major goals, quality of life. Okay, and the most important element in any stroke rehabilitation is must be carefully directed. That means carefully planned by the team members, well focused, and it requires repetitive practice. That maksud during practice it's not just come once a month, every 6 months, and then that's it. Okay, and it teaches new ways to compensate for any remaining disabilities. So like I said just now, many of the stroke patients affect their physical and also their communication functions. And basically the goal is to help the stroke patient become as independent as possible and to help them to relearn the skills that are suddenly lost due to the stroke. Okay. And what are the factors can affect the outcome of stroke rehabilitation? Okay, one is, of course, we are looking at the the severity and the degree of damage to the brain with each and then we don't want them to have a recurrent stroke. And also, what are the remediation what we are looking at here? Okay, whether we can restore the functions or we need to give compensatory strategies or techniques to help them to be more functional, and also how the patient can maintain the treatment that we planned for them, and as well as the reintegration. I'm sure the physiotherapists and also the OTs are familiar with it. How can we put back the individuals to the society so that they will be able to function in their daily living activities? Saya tak gerak balik ya. Mana tadi? Tadi dah okey dah. So the next slide is about the aim for stroke rehabilitation. Of course, similarly to the aspect of the stroke rehabilitation just now. So the aim is we want to prevent and manage comorbid medical condition. That's why we need the medical team, okay, by the rehab doctors and also the whoever teams that involved in the patient to maximize the functional independence. Okay, what we can exploit. What are the reserves or intact skills that the patient had after the stroke to optimize psychosocial adaptation of the patient and families. These are very important because it affects their social communication, their ability to involve in activities, as well as their well-being, okay, their quality of life, to facilitate the resumption and prior life roles and community reintegration. So what the patient can do after that, okay? And also the most important is to improve the quality of life regardless of their disabilities, okay? So one of the things that affected, okay, that we speech therapists usually deal with in the communication disorders, okay, or communication problems. And then stroke generally affect 1/3, and now the statistic has shown half of the patients who have stroke may have communication problems, okay? Because in our brain, basically, there is a part that controls the speech and also the language, okay? So the severity of the communication problem depends on where the brain, the stroke happened in the brain, as well as how much, to what extent that the damage is. And usually, problems with communicating will damage to the part that the brain responsible for language, and then usually it affects the left side of the brain. And what happens when someone has communication problem, okay, after stroke? Of course, their everyday activity will be affected. The way that they make conversation with people, they might not be able to answer the phone calls or make phone calls, okay? In some cases that in patient who have comprehension problem, they might not be able to understand the auditory stimuli, and many of them have reading and writing problem. They might not able to emails. Now we are using emails, okay, and also text messages. And also it will reduce the ability to carry out anything that they have done before stroke, such as it will affect their vocational, their employment, it will affect the way that their relationship with the family, and also the way their functions in the community. And what happened is when all of this affected, it will it occurred that the patient will have some withdrawal problem. They feel isolated, and also it affects their emotion, which is they have mood problem. Okay, so and then when they are unable to communicate, of course, it will affect the relationship with their families, the friends. They feel frustration, okay? Their relationship with their partners or spouse will be affected. And then in this case, rehabilitation is needed to mitigate the consequences. And one of the conditions of the communication, we call it aphasia. I'm not sure whether everyone have heard it before. So aphasia basically is a language disorder that affects spoken comprehension, production, reading, and writing. Okay, that means it can affect all language skills. Okay, the way that people comprehend, the way that the patient produce the language, the way that patient understand what they read, and also the way that the patient write. Okay, and it is estimated around 30% or even now 50% of patients who have stroke have aphasia. And the other condition is aphasia can also comorbid with the motor speech problem. For example, like dysarthria, which is a problem with the speech muscles, okay, where the patient has weakness or the incoordination of the speech motor movement, and also the apraxia of speech, which is ability to coordinate the gesture required for speech, which lead to difficulty produce the right sound. That means apa yang dia fikir kat sini, they cannot give the instruction to the muscle here on what they need to say. Maybe they are able to say the word bola, tapi kat keluar kat sini, the instruction, the sequence movement of the muscles tu bukan bola, maybe something else. Okay. So aphasia, yes, what happened? They are unable to talk in many cases. Okay. Usually people will relate they are not able to remember, but basically they are not able to process what they want to say, especially to recall the word in the part of the brain. Kena korek balik dekat dalam otak tu, dictionary apa. Kalau nampak kerusi, they're not able to they know what it is, tapi tak boleh nak access to the kita panggil dia punya kamus lah in the brain that controls the vocabulary. Okay. So yes, they know what they want to say. Okay, so do not expect that kan. Bila most of the caregivers kan dia cakap, oh dia dah tak pandai, dia dah lupa, atau dia dah in harsh word dia cakap dah bodoh dah balik macam budak-budak. But they are not. They know what they want to say. They understand, but they just unable to find the words. Okay, so it's hard for them to find. Some of them is hard to understand what they are saying. Their hearing and also their thought processes are unaffected. Macam saya cakap tadi lah, their process tu tak terlibat. Unless that the cognitive functions of the patient is affected by the brain injury, then that will be a different story lah. Okay, sebab cognitive function tu ada banyak kan. Right? And yes, reading and writing is one of the things that could affect the patients. Okay, so many of us only focus on the boleh cakap ke tak boleh cakap kan. So in the case of patient that needs to return to work ataupun return to college atau university kan, atau student kan, so we need to identify whether they are able to read or to write. Okay, especially their job ataupun the demands of their work and also academic to require them to read and write. So sometimes kita lupa benda ni. So bila dia dah boleh cakap, kita akan biarkan dia. Okay, dah function lah. Okay, tapi sebenarnya bila nak buat benda-benda yang suruh baca, for example suruh baca teks ke apa, dia tak boleh buat. So that's something that we need to look at as well. Okay, and spelling can also be a problem. Masuk tulis tu bukan setakat tulis biasa lah. Maksudnya ability to spell the word. So if you show them a picture of bola, whether they can spell the word bola atau tidak kan, that is matters lah. And some of them may have problem understand numbers because they have reading and writing problems, so calculation would be the problem, and understanding and abstract ideas may be impossible. Yalah, benda yang konkret macam bola pun tak boleh nak bagi tahu, apakah lagi benda yang more complex kan, contohnya macam gambar-gambar yang abstract. Okay, so when we do stroke rehabilitation, we must follow what the World Health Organization suggested according to their ICF model, International Classification of Functioning Disability and Health Model, which is, in this case, when it comes to communication, the impairment here is the speech or language. Okay, and the activity, when they have impairment of speech or language, they are unable to make conversation, they are unable to write, they are unable to read. Okay, and then what happened? In terms of participation, they are not able to communicate on the daily activities basis. Okay, so what we need, basically, we need to assess, okay, the patient thoroughly, and then in the end, the WHO aim is for the patient to be able to go back to society. So improve their quality of life, not only on the patient, but also on the carer or the family members. And in speech therapy, okay, we did screening tests and comprehensive assessment so that we were able to identify the presence of communication problem. In this case, we're looking at the language difficulties, we're looking at the motor speech problem, which is the dysarthria and apraxia of speech. Okay, I always encourage my colleagues, okay, speech therapist colleague, always to use any published assessment, which is a standardized tool, to provide a profile language disorder of the patients so that the result will be accurate and also the diagnostic will be more meaningful. So there's a lot of published assessment, okay, for that. So I think there are some in HRPZ as well. And also now communication assessment not only focus on the speech and language, but they also focus on the well-being of the patient to look at whether the patient depressed or not because of they are unable to communicate. And so one of the therapy that we focus is the behavioral therapy intervention for aphasia, okay, for the language. So if you look at this study, okay, they in 2016, they have done a Cochrane review on how the speech language therapy for aphasia was done. So many of the therapy basically focus on the very specific area of the language, which is the semantic system, which is how they process the words in the brain, how the sounds productions, okay, how they formulate the sentences, okay, how they tell story, how they make conversation, and all of these studies basically focus on the major language domain, which for the patient to be able to improve their comprehension, to improve their communication, production of the speech, improve their reading skills, as well as improve their writing skills, okay. So for example, some of the therapies that was focused is the conversational therapy, okay, which we focus on not only on the patient, but also the communication partner of the patient. In this case, many of them family members lah, ahli keluarga, okay, siapa yang paling dekat dengan dia. Because kadang-kadang when the patient came for the speech therapy, they only do the speech therapy during the session. Tapi balik there's no stimulation, kan? Whereby the stimulation must come in communication in everyday life. So what happened is the patient tu balik tak ada orang nak cakap. Husband pendiam, anak pun dengan hal sendiri. So there's no stimulation. So most of the time we have to consult the family members as well in order to support the communication avenue ataupun opportunity for the patients lah. Okay. And another study basically looking at there is a clinical statistically significant weak to moderate benefit of SLT for functions communication compared with no SLT. So that means every patient who have stroke and have communication must be referred to speech language therapy for interventions. Okay. So however, in this study they say no evidence for one therapy above another. So sometimes one therapy only focus on case studies, okay, atau case series, might not be able to generalize to others lah. But it is still very meaningful and useful for the patients and also for the clinician to do. And then one of the therapy that can be implemented, I think this is a new one, not really new one lah, tapi something that I ventured recently. I think it is similar to what the OT ataupun physio buat, kan? Constraint-induced movement therapy or constraint-induced hand therapy, something like that. In this case, it's a constraint-induced aphasia therapy, which focus on very intensively in the therapy. Whoever yang familiar dengan CIMT tahulah the program tu very intensive, kan? That the patient has to undergo the session 30 hours over 2 weeks. So I'm not sure whether the speech therapist can provide the service kind over here, kan? But it is possible to try lah. Not all patients lah, but the potential patients. So based on the Cochrane study, they found that this CIAT useful for improving chronic post-stroke aphasia, although there is no evidence of superiority to other techniques. That means it doesn't say that this technique is much better than any other language therapy techniques, language therapy approach lah. But something that the speech therapy can plan for the patient. Okay. And another one is the dysphagia that I mentioned because of the motor speech problem, where the patient has weakness and also incoordination or speech motor control. So there's RCT study showed that there is an effect of therapy compared to no therapy or placebo at level of impairment, but not for activity or participation. That means if the patient comes for therapy intensively, they showed an improvement, although the generalization has shown no significant punya results lah. Okay. And usually the therapy for dysarthria focus on the articulation exercise, focusing on how they produce the words. Okay, maybe they in the case of people with dysarthria or patient with dysarthria, they have a lot of speech error, banyak cakap orang kata pelat lah kan. Okay, and then modeling the correct pronunciation. Okay, a lot of feedback and also repeated items, because this is a drilling punya techniques. Use visual feedback, okay, from the audio recorder, from the video ke ataupun specific device like instruments, okay, software. In the case of patient with voice problem, they can implement disablement voice therapy and also controlling the speech of rate. So many of patients with dysarthria, they ada problem tak boleh control rate of speech. Sama ada dia cakap terlalu laju ataupun dia cakap terlalu perlahan because of their problem with the muscles here. Okay. And for apraxia of speech, selalunya kalau apraxia of speech, saya takutlah kalau patient ada, okay, because this is more problematic. Kalau patient yang ada stroke, yang ada aphasia, ada apraxia. So saya kalau ada apraxia memang penat lah, okay, because the therapy will be very tiring. Kalau saya ada 2 case pagi, and then the next case the whole day akan ambil my energy, because kita nak drill dia betul-betul untuk sebut kan, because it's about we want to replanning balik in the brain kan. Contohnya saya selalu cakap kat patient what apraxia is, kalau you Google, you type satu kataan kan, salah, dia akan pergi ke mana-mana kan. So the same thing, if the brain salah bagi sequential commands to the motor system kan, to the speech motor system, satu dia katakan kita nak sebut bola tu kan, tutup lidah, tutup bibir, buka mulut, lidah ni atas, lepas tu buka mulut lagi kan. Kalau kata the command suruh buka mulut, so that means dia tak boleh sebut bola betul. So satu command salah, everything salah kan sebut. So it's difficult to have this case lah. So tapi however, in my experience, saya cakap sepanjang 22 tahun ni, when I treat apraxia of speech, hanya berapa persen saja yang patient akan improve up to 80%. They are not 100%, 80%. But also that depend on the severity of apraxia lah. Kalau severity dia teruk, memang kita terpaksa cadangkan other mode of communication lah. Okay, because apraxia ni dikacau sikit banyak benda. So, programming in the brain kan, how do we want to fix it? Kalau komputer punya monitor punya motherboard kita boleh fix kan, tapi kalau otak macam ni kita nak fix kan, unless that the neurologist ada cara lah kan to fix that kan. Alright, so that is the the challenges when patient ada apraxia of speech. Okay, so what we recommend basically, okay, many of the behavioral therapy macam CIAT tadi ataupun therapy focusing on work finding problem, the speech therapy should provide it to people with aphasia as individual indicated to reduce their communication problem, okay, so that they can enhance their functional communication. But depending on the approach lah, okay, if the approach is more on functional, kalau dia boleh sebut 1-2 kata, then we go for it lah. If an impairment based, which is we look at the process of the language, that will be a different approach lah. Okay, and yes, CIAT just now can be considered, okay, for the therapy for people with aphasia. And people with dysarthria should receive rehabilitation to improve their speech impairment, because kadang-kadang memang dia boleh cakap, tapi kadang-kadang orang kata telur dia lari kan, kadang orang tak kisah, tapi some patient dia sangat kisah, dia nak treatment pula. Okay, and techniques, okay, basically differ from one patient to another depending on their problems, because dia bukan acuan. Okay, so each patient has different approach lah. And it can be used to treat the impairment of apraxia of speech as well, the behavioral therapy. Biological treatments, this is something that I wish to venture very soon. Okay, sebelum ni saya kerja hospital rehab kan, so saya tak ada alat ni. So when I joined USM last year, I just knew that the rehab doctor ada alat ni, dan di USM ada alat ni lah. Okay, so this is something that not new, tapi something that people are looking at now, using the non-invasive brain stimulation, using the repetitive transcranial magnetic stimulation, and also transcranial direct current stimulations. Okay, the thing is they give electrical stimulations to the brain lah, to the part that affected. I know that some private rehab settings either provide the treatment. So the treatment is either passive treatment, patient duduk je and then you bagi stimulation, ataupun active treatment. For me, is best is active treatment lah. While doing the electrical stimulation, we also do the speech and language task. So it will be it will enhance the process of stimulations. So yes, there are many studies reported both non-invasive stimulation enhance verbal production in patient who have aphasia. However, in order to conduct ni mesti ada license kan. That means you are trained to do that. You tak boleh macam beli iPhone hari ni dia tu boleh operate kan. So you need to be trained to do that. Okay. Okay. The next part is dysphagia or swallowing problem. I think this is one of the major things that usually occur among the stroke patient. One, the patient ada stroke, selalunya saya nampak dekat ward, doktor terus insert tube kan. Takut dia orang ada swallowing problem kan. Walaupun they don't know whether they have swallowing or not. Okay, problem or not. Okay, so yes, it's a very high risk for the patient to have dysphagia. Okay, the percentage is very high. All right. So most of the patient have pharyngeal phase dysphagia at this part. Okay, the telan, dia tak ada banyak residu dan dia ada risk for aspirations. Okay, and usually we want to look at whether they have silent or non-silent aspiration that could lead to aspiration pneumonia. Maksudnya jangkitan paru-paru lah, which is we want to avoid lah. And also a lot of dysphagia cases also associated with other medical condition complication such as dehydration, malnutrition, mortality. Okay, belum lagi ada patient saya mati sebab saya manage. Okay, tapi very important because the swallowing is life and death situation lah. If wrong management can lead to patient boleh masuk kat dalam paru-paru lah. A lot of things can happen. And so therefore, detecting and managing dysphagia after stroke could prevent medical complication and reduce the length of hospital stay and socio-economic burden. Because bila patient ada dysphagia, banyak dia kena pakai, dia kena beli susu kalau dia tube feeding, okay? Susu tu kan murah lah, mahal, okay? And the tube also nak kena tukar, okay? Certain period of time, okay? So it is important at early stage we screen the patient first, okay? I'm not sure how the setting here, okay, but when the patient dekat ward selalunya, doktor akan refer for dysphagia immediately. So in our practice, we have to see the patients within 24 to 48 hours lah, so that we nak tengok dia punya swallowing ability, okay, boleh ke tak boleh. So in the case patient yang tak insert tube lagi, so we want to see whether they safe oral feeding atau tidak kan. So selalunya benda tu penting, okay. So the sensitivity and specificity to detect aspiration are very high, okay. So one of the systemic review studies showed that, okay, more than 87% of patients showed dysphagia problem after screening, okay. And then it can be used any of these screening tools lah. The most common that speech therapy guna adalah adaptation from the Toronto website swallowing screening test lah, okay. Dan now ada juga yang dah start guna gas, okay. And yes, I would say that screening can be done by anyone, okay, that is trained for screening of dysphagia, not necessarily speech therapy. However, cuma orang tu selalu jumpa patient dysphagia atau tidak lah, because when you do screening, you have to look at all the symptoms of dysphagia too carefully, okay, to decide whether to refer the patient for comprehensive dysphagia assessment or not, okay. And when we do the screening, we have to look at the alertness during the assessment, okay. Usually we look at dry swallow test, ask the patient to dry their saliva, ileodora, and also kita boleh bagi dia air ataupun certain food lah that safe for the patient to look at their swallowing abilities at that time, okay. However, after the screening, it is important for the patient to be referred for instrumental assessment, okay. So I don't know whether kalau orang boleh screen, I heard lepas screening terus dia kata okay boleh bagi makan. Because when we do screening, we only can identify problem at this part, oral part. Tapi dekat dalam ni kita tak tahu, kita tak nampak. Okay? Because that is the disadvantages of screening ataupun clinical bedside examination lah. Because this part tak nampak. If in the case of patient kata boleh telan, selamat telan, tapi kita tengok bila kita buat video fluoroscopy swallowing study under X-ray ataupun insert the scope kan, the simple scope, patient ada silent exhalation. So siapa nak jawab kan? So saya selalunya takkan based on that lah. Okay, saya akan walaupun selamat ke tak selamat, saya akan refer pada instrumental assessment. Okay, so I'm sure there are service for that in your hospital lah. Saya tahulah dulu saya kena tengok atau buat tu benda lah tu kan, fees tu. Okay, so yes, ideally of course the gold standard for this major assessment is either patient go for VFSS, video fluoroscopy, ataupun FIS lah, the endoscopic examination. Okay, so because we can get the accurate result of the swallowing ability. So using these two assessments, we can detect high silent aspiration rate in studies so that 67%, and also indicated that bedside test alone, maksudnya buat yang tepi katil je, could not predict the risk of aspiration. Itu yang saya cakap tadi. Okay, and in one study compared the bedside screening test versus VFSS, they found that 14% of patients who passed the screening test showed aspiration in VFSS, and diet recommendation will change to more conservative level. Maksudnya diingatkan masa buat clinical bedside tu allow patient to ambil bubur. Tapi bila buat VFSS instrumental, sebenarnya patient tak selamat pun, kena insert the tube. So you see the difference kan. So kalau patient balik rumah and then makan dan masuk dalam paru-paru, kena jangkitan paru-paru, susah kan. So that leads to mortality lah. Okay, so of course when it comes to treatment, kita guna behavioral interventions lah, whether we can restore the function, what we call it rehabilitative treatment. Okay, if we can restore the function of swallowing, we will try to restore it. Otherwise, we might provide a compensatory strategies. Compensatory strategies is for the patient in the case of they are safe for oral feeding. Maksudnya kita providekan dia certain strategies bila dia telan tu dia selamat. Okay, sama ada dia kena tunduk ke atau dia kena sengat kepala ke, atau kan, that is one of the strategies. Ataupun dari segi dia punya makanan atau air lah, consistency and also diet modification. If the patient has not ready yet to take solid food, what is the best diet modification for the patient to take? Maybe semi-solid ke, blended rice ke, even water pun kan ada different consistency from yang normal liquid sampailah kepada honey tea liquid dan juga puding punya thicken yang liquid. Okay, so yes, usually we will provide both the rehabilitation and also the compensatory strategies lah, depending on the needs of the patient. Even patient on the tube feeding pun kita still lagi kena buat dia punya treatment. Okay. So again, another thing is one of the treatment also the electrical stimulations. Okay, the neuromuscular electromyography stimulation. Dulu alat dia besar, sekarang dah kecil dah. So I'm waiting for USM to buy it. Kita dah minta, okay, hopefully we can get it lah kan. Because this is something that we do. We give stimulation to the part of the muscle for swallowing, gives electrical stimulation at the same time. Also, we ask the patient to swallow lah, so that we want to see the functions of the muscles too during swallow, so that we can get the baseline and then we can see whether the treatment that we provide effective atau tidak lah. Okay, and I don't know about acupuncture. I came across about this. Okay, I know that my previous patient ada cakap lah, especially Chinese patient, dia kata dia pergi acupuncture, okay, to help with that lah. But not sure how effective it is. But based on this study lah, okay, they do RCTs, okay, on the 256 patients, okay, using the acupuncture. However, the study found that it could be not acupuncture alone. It could be because other treatment yang kita bagi, behavioral treatment juga, okay, not just acupuncture alone. Tapi in the end, we can consider acupuncture as one of the treatment of this region lah, okay. But how effective is just acupuncture alone, that one I'm not so sure. Okay, so that's what the RCT study showed, that it could be concurrently with the other intervention plan goals as well. Okay, non-invasive again RTMS. Okay. something that can venture out, but I'm not sure how it is done there in Malaysia. I haven't heard anyone working on patient with dysphagia using this RTMS and all that. Okay, so maybe perhaps that when we identify where the location of the damage that affect the swallowing, then maybe we can stimulate around the area or area that is still preserved after the brain injury. Okay. Oral hygiene is another thing, okay, that is important for patient with dysphagia. We have to stress this, even patient on tube feeding ke ataupun oral feeding, sometimes bila dia lama tak telan ataupun tak guna saliva dia berkumpul, okay, oral hygiene is very important. Kadang-kadang boleh, because I know kita ni patutnya prevent daripada bakteria whatsoever, tapi bila banyak sangat dah berkumpul sangat, dia can turn into infection. Saya pernah ada patient, a few patient yang dalam mulut dia dah jadi macam keras, dah block the airway tu dekat back of the tongue tu. Nak kena scrape tak boleh, okay? So dia dah keras, dah macam crust kan? Macam apa? Roti keras kan? Yang kena apa tu? So so macam mana kan? Tapi lepas tu saya minta dia bubur air suam pun tak boleh bubur, tapi anak dia pandai balik rumah guna oil, air kelapa pula coconut oil kan? Macam mana? And clear. Bila lepas clear tu, oral hygiene dia better semua, patient lepas tu terus boleh makan. Okay, so that's why oral hygiene is very important. Okay, because especially patient bila ada trachea tube kan, they use mouth breathing kan, so they akan rise out the mouth. Okay, and then many studies have shown that oral hygiene is very important as part of the treatment of dysphagia as well. Okay, and enteral tube feeding. Okay. This is the case patient yang tak boleh oral feeding yet lah, oral lah, because tak selamat lagi. So enteral tube feeding is very useful to help them to have sufficient nutrition and also hydration. The only problem, there are different types of tube feeding, NG atau PEG. Okay, so yes, I want to stress this. PEG placement should be considered in stroke patient with dysphagia who requires enteral tube feeding for prolonged period. Bila kita buat assessment at the very beginning, kita dah tahu dah sama ada patient is going to be a prolonged tube feeding atau tidak, prolonged tube feeding atau tidak, kan? Even more than 4 weeks, kan? So sepatutnya tube feeding tu tak boleh lama lebih daripada 4 weeks. The NG tube, okay? Because kena insert dan all that, kena keluar insert dan keluar. So that's why kena pack tube feeding tu, sebab dia after patient dia akan banyaklah trauma nak masuk semua kan, and then some patient tak suka, dia akan tarik keluar apa semua kan. So dia akan bagi injury to the nasal cavity and also the esophagus and all that. Tapi masalahnya kat sini, we don't practice that. Right? So saya kalau patient at acute stage, saya tahu dia akan prolong tube feeding, saya akan terus suggest pack tube. Tapi masalahnya, because stigma orang kita, kena tebuk perut, takut. Okay? That's the problem. Saya cakap bukan tebuk perut macam Caesar nak beranak tu, saya tu buka kecil-kecil dia kan, kata, and it's so safe kan, and very non-invasive kan, tapi sebab orang tak nak, dia kata sebab kena tebuk perut, kata, dia sangguplah pakai tip kat sini sakit apa semua kan. And sometimes okay, patient tak kisah pun, tapi family members yang kata yang over kan, tu masalahnya. Kayak ada few patients yang sekarang ni susah nak convincekan so pakai pet tube walaupun dah setahun pakai NG tube. Okay, in Western country, they memang tahu this is the gold standard. Okay, for example, last year I had a patient who were Malaysian from US kan, memang kena bleeding stroke. Dekat sana memang dah tahu dah patient tu punya swallowing tak ada problem. Bila balik Malaysia masuk dekat jumpa saya, bila saya baca report memang dia dah siap dah insert pet tube dah. Immediately after dia kena stroke tu, sebab dia ada prolonged tube feeding kan. So beza kan the awareness kan. Bukan saya kata benda ni akan selamat. Of course, bila kita cadangkan pet tube, the gastro doctor akan buat assessment dulu according to the patient health condition. Tapi of course, this one is siapa yang mak. Saya selalu cakap, bayangkan you ada tube kat sini, you telan ada tersekat sini, macam you telan ada tulang ikan, tulang ayam kan. So sama dah tube tu. Okay? So that is and then susah nak breathing juga only one of the nose is blockage kan. Itu yang masalahnya. So will it improve the stroke rehabilitation? Yes, many people considerable progress following the illness, provided yang faktor-faktor tadi itulah, okay, especially intensive stroke rehabilitation treatment lah. And with practice and support, okay, People with aphasia, also communication problem or swallowing problem, can continue to communicate and continue to improve. Okay, so yes, the speech language therapist is the best person to advise the type of communication or swallowing problems and the amount of progress that a patient likely to make. Okay, terus kita ada prognostic factor based on the assessment and also the other factors. Okay. So to wrap up my presentation, yes, stroke recovery varies from one person to another. I think many of us know that. And susah nak predict. So selalunya golden question is, berapa lama saya nak cakap balik? Berapa lama saya boleh makan? Saya kata saya tak boleh bagi answer. Kalau mana-mana speech therapy bagi kata 2 bulan, 3 bulan, dia kata itu bukan speech therapist, itu hantu, saya kata. Okay? So no one knows, okay? Alright, even patient yang maybe ada good prognosis, tapi kalau dia ada factors yang macam-macam, family doesn't support, patient demotivated, macam tu semua, it will affect also the recovery process. Okay, so the successful of the rehabilitation depends on the physical function. Yes, so because most of the time when stroke patient, dia fokus pada physical, dia boleh jalan tak boleh jalan. Okay, cakap tu kemudian. Okay, the emotional of the patient, the social of the patient. Some people, macam saya cakap tadi, bila kena stroke dah tak nak jumpa orang, duduk rumah, tak nak keluar. Okay, whereas sebenarnya tak ada masalah pun, kan, regardless of the disability, and also based on the therapeutic treatments lah that is given to the patient. And yes, the rehabilitation takes time. It's not just 1 month or 2 months. However, some patient kita percaya ada spontaneous recovery, kan. Masa selalu orang cakap, oh, orang kat sebelah rumah tu dia kena stroke, sebulan dah boleh cakap. Kita kena tengok juga orang tu punya stroke macam mana, kan. So selalu orang ni kawan saya, kan. So it's always like that. Tapi recovering from a stroke can be a long and frustrating experience. Okay, thank you very much. That's it. Saya tak laju, saya try to speed up. Okay.
Thank you to NG as well for a great presentation and informative presentation. So I will bring to member of the floor for information. If you can get to 1 to 2 questions to share some information from anybody.
Ya, betul. This way je.
After 50% yang clinical assessment of this measure tu, actually ada yang ambil macam apa, I problem lagi yang sugar cell. Do you recommend do instrumental assessment of this patient in all patients or?
Depending on, okay, when we do the clinical backside examination, kan, if the patient we think that do not have any symptoms to of dysphagia, waktu screening dia juga clinical backside is important lah. So that's why saya cakap kena well-trained person to do that, to identify the symptoms. So the symptom kita tengok tu whether they have oral dysphagia symptom ataupun pharyngeal dysphagia symptom. Okay, it's just me lah. Okay, some people dia percaya apa yang dia dengar, apa yang dia buat examination tu, dia kata tak ada problem part ni. Especially part ni tak ada problem, tapi part ni dia check tak ada problem. There are some indication to to ensure that this part tak ada problem. Tapi for me, it is best to refer the patient, any patient, for instrumental assessment, regardless atau FIS procedure ataupun VFS procedure, to ensure that bukan kata selamat tak selamat, whether patient boleh take makanan atau air orally, tapi the most important is which consistency ataupun diet modification is safe for the patient. Bukan kata patient tu boleh makan, dia boleh makan everything. Okay, dia ada different consistency. Macam saya when I did a QA study, kan, dekat in 2017, kan, when I was in KKM lah. Okay, and that QA study won the national competition. We focus on the compliance rate of the patient, okay, of this major patient, towards the diet modification dengan liquid consistency. Even bila kita dah provide kita panggil prescribe lah, kan, you boleh selamat nektar liquid consistency ataupun blenderized diet, tapi patient still ambil benda lain macam solid food ke, kan, dia dah tak tahan nak makan roti canai, makan roti canai. Tapi sebenarnya roti canai tu boleh je nak tukar pada blenderized, kan, kita blend je lah, dia nak yang sedap lah, kan. Kalau asalkan tekstur dia tak sedap, saya pun tak lalu. Okay, tapi because we are concerned the safety of the patient, okay, the swallow safety, alright. Yang tu saya kata the clinical bedside unable to determine 100% correctly whether patient is safe atau tidak. Because during the instrumental assessment, kita akan try different consistency of liquid and also as different diet modification to ensure patient safe ke tidak. Yang mana? Kalau patient safe, normal diet, solid food, then kita allow the solid food lah. Cuma waktu tu sebab bila berlaku kat sini, kita tak nampak dia ada residu. Bila dia telan, residu tu maksudnya bila lepas dia telan tu sebenarnya dia tak telan habis. Banyak tertinggal kat sini. That residue can the risk of aspiration. Dan tu yang kita nak elakkan. So pada saya, if you ask my personal view, I would refer the patient for instrumental assessment despite dah buat clinical bedside. Clinical bedside tu cuma nak alert whether patient ada symptoms yang macam mana. So that bila dia pergi instrumental assessment, kita akan lebih lebih accurate lah bila kita tengok problem tu. Okay tak?
Any other question? Okay. If there's no more question, I'd like to invite the finance to deliver the certificate of appreciation to our respected TGC and representative. Please welcome.
Okay, thank you very much for listening. Okay, dan juga saya minta maaf lagi saya lambat sikit tadi.
With that, we have to welcome to the end of the busy session.
Okay, just tambahan tadi yang regarding APC tu. Once kita dah collect that my speedy point, it is a responsibility pegawai itu sendiri untuk apply the APC secara online. Okay, bukan lagi pihak pengurusan. Kalau lama-lama dulu kita isi form dan submit kepada pengurusan dan pengurusan akan hantar kepada MMC. But starting a few years back, semua secara online. Dan bayaran 100 tu boleh tutup kembali dengan pihak hospital, dan hasil daripada perbincangan pihak pengurusan tempoh hari, kita akan tutup claim untuk RM100 bayaran bagi APC 2024 pada akhir bulan 9. Surat maklumat akan diedarkan kepada setiap jabatan. So tak kisah, kalau kata nak apply APC 2024 31 Disember 2023 pun tak apa, tapi tak boleh claim RM100 tu. Cuma untuk APC 2023 2024 perlu apply dengan MMC paling lewat akhir bulan 12, because Januari 2024 kami akan tutup daripada setiap jabatan, daripada setiap pegawai nombor APC bagi tahun 2024 bagi melayakkan anda bekerja di bahagian klinikal. Sekian, Assalamualaikum.
Thank you so much. September last year. Oh, almost 1 year lah. So ni saya jadi on time terus. Lama kita tapi lama kot. Saya nak ada tapi biasa mau permisi. Okay. Good luck, all the best. Okay. This. Last year September aku pindah sini. Kan, cengkak lah pelan-pelan. Alah kerja je apa ni? Doktor Diana. Yani. Last year September. Ada. Oh, ya ke? Nombor yang sama lah. Okey. Ada tinggal lagi. Nak scan macam Starbucks Kelantan Okey. Cek berapa ayat ni? Dia tanya ke sini. Oh, dia masa buat posting ke atau masa lepas dia habis? Oh, okey, masa tu. Minuman? Okey, mana sikit lah. Saya rasa pun tak rehab, sebab saya tak dengar pun. So, masa saya tinggal rehab tu, keluar KKM tu sama. Taklah lupa. Tak, saya okey. Tak, saya memang PhD. Sebab saya tengah berikan PhD dah, tapi saya nak mention banyak akademik ya. Sebab kalau kat start saya senang boleh buat research banyak sekali. Sebab kalau saya buat research tapi limited time. Dan sebab kita punya kerja kan cleaning kan. So bila fikir balik, mana mesti buat itu kat ada sini, saya rasa USM pun mesti dia punya team rehab pun okey. Okay. Hari pun last year saya jumpa Dr. Faizal dekat Queen. Dah pindah dah. Dia cakap, dia kata saya pun nak keluar. Dia kata. Sebab dia tak tahu dia keluar sebab dia kena smart station kat KK ke apa ke kan. Okay, tak ada. Okay, macam nak cabut terus. Okay, Dr. See you. Saya orang ni nak. I pun lah. Okay. Okay. Alright. See you.
Kenapa hari ni? Jadi kenapa lah? Pada pasal dah. Lain dengan suara
Tak nampak.
Oh.